So this is where I studied in Egypt. This is Qasr Aini University and the hospitals there. This is where we started a long time ago. And this is why we talk about low back pain, because it's one of the most common issues in the world. Okay, nobody will not get back pain. Everyone has to have back pain one day of his life. No one will skip it. And it is 15% of the sick leaves that goes to the companies are from back pain, and it's the most common cause of disability in persons after 45 years of age. But the good thing is 80 to 90% will get better by their own, even if we don't do anything, so this is a good thing about us. And only 1% will have root symptoms, and the herniation is only 1 to 3% of the patient. Like I'm talking about generally, I'm not talking about disc patients, the ones who come with the back pain. And 80% with sciatica will eventually recover. And incidence is higher in smokers than non-smokers, and we'll get to know why. No one smoker. Anyway, so back to the anatomy, we talk about two vertebrae and a disc. This is what we call a functional unit. With a vertebra above, a vertebra below, a disc, and there is a foramen through which the nerve goes out. Okay, and there is a joint in the back, and there are some ligaments around that. So when we talk about this, or any place of this can cause pain. It's not only the disc. We always forget the other things around it. This is from above. We can see here that the disc is in the middle. There is a nucleus pulposum. There is an annulus around it, and there are the sac of nerves in the middle. Two nerves coming right and left, and you can see the whole thing there. So what can cause a back pain? The disc, the degeneration, the muscle, the ligament, and maybe something in the skin itself. Sometimes, many times patients come to me with, I have this thing here, and I find it's a lipoma, it's a small lipoma. And this lipoma under the skin is hurting him. And he is relating the sciatica in the other leg towards this. No, it's lipoma is painful, sometimes it's painful, so, and he wants to take it out. So, but tell me, this is the cause of the sciatica? I tell you, no, it's not the cause of the sciatica, it's something else. The pathophysiology, why your back hurts, it's because of aging, which we call degenerative disc disease, wear and tear, repeated stress, especially for people who work a lot or drive a lot. We always forget about driving. People who are living in Sharjah and going to Dubai. Same people who are living in Dubai are going to, I had one patient who was living in Ajman and go to Abu Dhabi every day. So these things are very bad for the backs. Injury or trauma, when it's like acute trauma. Genetics, of course, some families have more risks than others. Obesity is weight because of that, especially when there's a more belly, it goes on your back. And ischemia through smoking and immobility. Smoking affects the blood vessels, we understand that, but immobility, why? Because the disc does not have a blood supply. The cervical disc and the lumbar disc, they don't have blood supply. There is no artery to the disc. The disc gets its nutrition through inhibition from the surrounding tissue. So as long as there is stagnation, it does not get any nutrition. So you need to move around. Don't sit on the chair for like more than 2 hours without moving. So please go up and examine your patients. Don't just sit and write papers. So it's a good thing to examine them, and they were happy that you examine them and you're touching them, and we'll get to this touching thing later on. Now, here we are talking about the pathology. Why do we have back pain or radicular pain or other things? So when we're talking about back pain, usually there is a disc tear, as the first picture up. You can see here with the tear, and the disc starting to go out. It did not go out, but it is just tearing through the annulus. This usually causes a lot of acute lumbosacral pain, like severe acute pain. This usually is, the picture is there. When the tear goes out, and the material goes out and touches the nerve, then the patient will get radicular signs. It will reach his leg, and it will hurt him so much. And he will be screaming out of pain with the touch of this. It's said that this disc is, the body acts it as if it's a foreign material. It's just like, because the disc material is usually it's done when the patient is baby, like in the crying life and so on. So the body acts as a foreign object. Radicular pain foraminal stenosis, neurogenic claudication, this is with degenerative disc disease when you can see that the joint became ugly and there's a lot of fibers and a lot of fibrosis in the area and there's a lot of pressure, so it will cause pain due to foraminal stenosis. You can see here, when the material became less, the joint became smaller, not like this one, because the size of foramen is related to the size of the disc itself. So this is why there's foraminal stenosis, and also the canal becomes smaller because of the fibrosis there. This makes stenosis in the spine. The presentation, so it comes variable. It comes to you with back pain. It's axial because of the disc or the facet, it's particular in his leg, there's muscle spasm, there's list scoliosis, there's numbness and paresthesia in the legs, and neurogenic claudications mean that he can get like heaviness in his legs or his thighs. And this is usually very common in the lumbar canal stenosis, the older type of patients. How the patient comes to you, it's a very important thing. Is it acute or chronic? Acute, like now, yesterday I was fine, today I have a big problem. This means there is an injury. So it can be from just a muscle pull or a rupture of one of the joints, ligaments, or disc tear. This can be something like that. Chronic pain is having this for like a few weeks, a few months, a few years. Then this is a degenerative process that's happening over time. This is something else. Pathology is different, and your approach should be different also. How? History, examination, manifestation, like any other specialty in the world. History, examination, and investigation. You cannot skip one part. History, lot of things. Age, type of work, trauma, medical disease, surgical history, fever, radicular pain, bladder symptoms, it's very important. Neurogenic claudication, history of lumbar punctures, drugs, steroids, pregnancy, allergy to medication. Allergy to medication is very important to ask about, because many times the patient will not come back to you if you give him something he was allergic to, and he will just like say, you can lose a patient out of something simple question like that. And ask the patient always about medicine. And when you write in medicine, ask him, he comes to you and I did not get better. One good question, did you take the medicine I wrote to you? And believe me, you'll hear it many times. No, I didn't get the medicine. So coming after 1 week, and you think that he's taking the medicine, and he comes to you without taking the medicine, and he's expecting to be good. Investigation, the simplest. X-ray, MRI comes before CT scan because we want to look at the soft tissue compression. CT scan is more for the bone and for post-operative. Myelography is long lost, but still sometimes we need it when the patient has a fixation and we want to see if there's still a root compression or not. EMG and NCV, as neurosurgeons, we don't use them except when we have nothing to say to the patient, when we don't have something that can justify what we are telling him. So we go to our friends and tell them, please do something, tell us something that we don't know. Discography is a very important thing that we use now, especially with the upcoming era of the endoscopic spine surgery. We are back to doing discographies more. And bone scan if there is like we are afraid of like some infection or side surgery. So, some pictures. So I get this enhanced picture to try to give you an idea about what we are talking about. So this is what I will get, and this is the picture. You can identify how the disc material came out from the disc and pressing on the canal. And here you can see on the other one how much pressure you can have on the right side. This is another one for degenerative disc disease. The advanced picture can show you how much pressure you have on the spinal canal and how this is the MRI. Treatment, we go according to the presentation. Generally talking about conservative treatment, pain management, and surgical treatment, the same things. Okay, I started with this for one thing. Touch the patient. Put your hand on the patient and see where the pain is. I started with this because many patients come to you, I have back pain, and then you assume they have lumbar pain. Sometimes the pain is here, sometimes the pain is here, sometimes the pain is here. In coccyx, it is pain in the coccyx is very common, and sometimes it has no trauma before. Usually we treat this with conservative treatment, and then after that we treat it with cushion, medication, and so on. It's not very good a block like that, and usually very good result. Now, back to our normal things. The radicular thing, the patient comes with radicular pain related to a nerve root coming down, paresthesia, weakness, diminished reflex, there is nerve root problem. There is compression of the nerve root. So in this case, I will start by doing an X-ray, an MRI, CT if I'm not sure if there is one involved or not, and NCB and NG sometimes to identify if this is a peripheral nerve or like a nerve root compression in the spine. This is a foraminal disc. Some people will pass this picture because they cannot identify the pressure here. But the trick in this, look at the picture above, the disc above and disc below. You can see the nerve root in the foramen. You can see the nerve roots here. You can see that this nerve root is compressed. The ones above and the one below is okay. You can see? Yeah. Okay, so this is a nerve root compression. This is a foraminal disc. This disc is in the foramen. In this case, we start by medical treatment, physiotherapy, and sometimes transforaminal injections. It's a very simple thing. We put the medicine inside the foramen. Surgery, in this case, if all of this fails, we go for surgery, we go for neural decompression, laminar foraminotomy, discectomy, sparing of the joint, or transforaminal endoscopy. These are pictures for the injection, how we put the injection around the nerve root, around in the foramen. This here, another injection, here, another injection. There, this is an endoscopic posterior, this is endoscopic transforaminal, and this is intradiscal injection. Now, if the patient comes with neurogenic claudication, this is usually there is a canal stenosis, like a pressure on the canal itself. We see it's very thin, usually it's an old lady around 60, 70, and she says that she's very happy when she goes to the supermarket because she bends from the car and she can move more. This bending thing opens up her spine and then she can walk more. This is a very nice thing to hear about a patient with canal stenosis. Physical examination is usually normal, but you can elicit signs with exertion. And you have to differentiate when the patient has claudication that to see if there is a vascular insult or not. This is like a picture of canal stenosis. You can see that the canal is very tight at multiple levels. In this case, we also start by medication, physio, epidural injection sometimes. In case of surgery, we usually do some decompression surgery through midline laminectomy. And sometimes we even lead to fusion, and there is something called the spacer that I am not very fond of, but it is there. It helps in some cases of canal stenosis. This is called the spacer, the one on the left side there. It should elevate the two levels and make this. If you see it one time in the X-ray to know that it's because some of us does not know what the picture is that they have. And this is like a wide laminectomy to decrease to decompress the spine. Axial back pain. So I have the back pain. So it's in the back. Either it will be transverse or going up down. Usually if it's transverse, it's L5S1. Going up and down is L4-5, but it's mainly in the back. It's when you wake up sometimes, when you turn around, there's a lot of things. I know it all looks like the same, but sometimes you have to dig in the details and try to hear the patient well, to try to see where should I expect the pain coming from first. As usual, the activity decreases with rest, the pain with activity and decrease with rest, anterior thigh pain, and improves with extension and increase with flex. MRI, usually there's a black disc. Black disc means that the disc is black, and there's osmotic changes, and the CT to see if there is osteophytes. This is a black disc, and as you can see, it's only a small bulge, but it's very painful sometimes. medical treatment by physiotherapy, and then physiotherapy and epidural injection, and surgery through laser and nucleotomy. Or sometimes if these fail, we go for a fusion like an ALIF or a PLIF or a TLIF, which is basically, it's interbody fusion, IF, but how we go there, it is, we like to have nice names. So TDR also is a total disc arthroplasty through anterior approach. We remove the whole disc and put a new disc. This is all things are for having a bad disc, and there's something called the PERC disc. This was only trials. They tried to come to here to this country, but still they are under trials. It's not going on well, but I believe that it was a very nice idea. So basically what we go in and we do a discography and we see if there is a leak in the dye in the disc or not. There is no leak, then we can go ahead and do a TDR, which is the first one there, or here in ALIF, where we remove the disc and put a fusion. So the disc is mobile like the artificial disc on the working shoulders. Here, this is the whole of the PERC disc. It was this thing. They wanted to put like a gel pad inside the disc to a small hole and make it like a pad. This, on the paper, or how to think of it, it's a good idea so that you have a movable disc without having any screws or so on. But it had to be like a lot of things. It had to be that it's intact, the joints are okay, and the patient is willing, and so it was very difficult to go over that. Axial pain with facets. So this one, when you have back pain, but it's more on the both sides. When you have the pain on both sides, and usually it's when you wake up from the morning, and patient is usually in his late 30s, early 40s. He had this for a long time before. He has pain in his lower back, especially when he wakes up from bed. He gets a lot of time to wake up from bed in the early morning, and he has a problem if he wants to turn in bed right and left, so he feels a lot of pain in his back. This is usually axial pain. Sometimes there is radiation, and MRI, there is a disc degeneration, but you will find the facet joint changes. So usually in these cases, you cannot tell 100% from the history of your examination, but usually we do a diagnostic facet injection, and this is something here you can see the joints really big, and they start to turn around and they show some sort of tropism. In this case, we start usually, and then we do an injection in the facet. Our radio frequency and fusion if failed. So here in this one, you can see this small point is the L1 of the needle. You can see here the needle going to the joint, and here this is the radio frequency, and this is the radio frequency thing that we use, the machine. And there it is when we put the needle also, that we put the needle in the joint and then we do the radio frequency. Radio frequency is using this kind of heat to make block for the medial nerve branch going to the joint so that the joint is not hurting. So we start by injection first, and this injection blocks the nerve. If it works for like 3 weeks, 1 month, okay, well and good, we can go ahead with doing the radio frequency. This is a degenerative disease of the spine, a big degeneration, and in these cases, usually we need some changes. We can start by the conservative, by injecting the joints and doing epidurals and so on, and doing physiotherapy, but if the patient fails, then most probably we need to do something like that. This is not major, this is like a normal surgery that we have to remove 4 discs and put some screws to make them stable. If you think this is big, wait for the next. Not the one after that. Spondylolisthesis, when there is there is instability in between 2 vertebrae. There is pars fatigue fracture. I've seen it in young patients. The youngest I've seen, it was yesterday, a small boy who is around 10 years old. I saw him with a fractured pars. This was like a new young time. Usually we see it around 17, 18, 20, and all it's degenerative in the old age. So it comes with back pain and leg pain, and flexion extension views are mandatory, like we were talking about before in the cervical, because it shows the movement of the segment. CT will show the fracture and MRI will show the compression. Here we can see L4-5